brain. Don't say we can't, oh, just don't say another word. These thoughts you've imagined aren't real, aren't adding up. You fetched your ideas from nowhere, all from another world. Your logic.
Hello friends, and welcome to this next module on vector-borne disease. We are going to discuss yet another disease, that is lymphatic filariasis. If you talk about lymphatic filariasis, the various topics that we will be taking is we are going to discuss the basic epidemiology and background about lymphatic filariasis and how the country is progressing towards elimination of lymphatic filariasis at a national level and WHO at international level. So we will talk about the epidemiology of lymphatic filariasis. In epidemiology, we will talk about the agent factors, host factors, and environmental factors. Next is we are going to talk about the clinical features of lymphatic filariasis. Next, about the diagnostic modalities. And finally, about the prevention and treatment of lymphatic filariasis under the National Vector-Borne Disease Control Program. So please, just to remind you again, as I have done in the previous lectures, that this video module also goes in conjugation with the lecture on National Vector-Borne Disease Control Program, which may be found under the heading of National Health Programs. So once you study this video, once you do this video, please go and just have a look at the vector management area under the video module of National Vector-Borne Disease Control Program. So let us go and start about the basic epidemiological factors about lymphatic filariasis. MCQ number 1 of the day. It is caused by 3 organisms, lymphatic filariasis, Wuchereria bancrofti, Brugia malay, Brugia timori. So out of these, in India, predominantly we have Wuchereria and the Malay, that is Malayan filariasis or a Bancroftian filariasis. We call it as a Bancroftian filariasis or a Malayan or a Brugian filariasis. So these are like predominant in India. Mostly out of these both, if you see that maximum 90% of the cases are actually Bancroftian filariasis. So that was just a brief. I would also like to tell you that this disease, lymphatic filariasis, is under the WHO neglected tropical diseases, and the target for our country is to eliminate lymphatic filariasis by an unofficial date of 2020. So to eliminate lymphatic filariasis, various programs will be there, and that is how we'll be discussing about the epidemiology, the understanding of which will be actually implemented by the National Health Program. So I just wanted to discuss that the elimination level is by 2020 and this disease has to be eliminated. So next is about the agent factors. Please remember that the Bancroftian or the Wucherean filariasis, this agent has a propensity to have nocturnal periodicity. If you talk about the life cycle, the man is the definitive host. What do you mean by a definitive host? Yes, try saying, what do you mean by a definitive host? Definitive host is the host. I think you must have done it in microbiology or in community medicine. In the initial lectures, we talked that what is a definitive host in which the sexual stage of the organism will be completed. And mosquito is an intermediate host. So if you just have a look at the life cycle, if this is the mosquito, there is the larva which comes in, the mosquito. So mosquito takes the blood meal. So in this blood meal, there is excreting of the microorganism. Then there is larval stage. The larval stage will pass through stage 1, stage 2 and stage 3. Now the stage 3 larva is the infective stage. So it goes through stage 1, then 2, then 3, and 3 is MCQ, 3 is the infective stage. Now this infective stage, this larva this mosquito can go and attack a human. So once it attacks a human, this larva goes into the human and there is maturation. After maturation, again the mosquito picks up the organism and there is egg sheathing and then again larva. So now the phenomena which is happening is a mosquito man cycle. The point is that in a mosquito there is no multiplication. There is only one microorganism giving another, and then in human it is only development. So therefore we say that this cycle is what? Cyclopropagative, cyclodevelopmental, or developmental. So this is a cyclodevelopmental transmission. This is a cyclodevelopmental transmission where there is no change or no multiplication. That is a very important point, that there is no multiplication of the microorganism, but there is only one microorganism giving rise to another microorganism in a different shape, size. So we have a cyclodevelopmental transmission for lymphatic filariasis. Next is, if you talk about the mosquito, when will you call this mosquito to be infective? It is usually seen that one microfilaria in a mosquito, in a human, may infect approximately 2.6% of the mosquito bites. So even one may be so much infective that it infects 2.6% of the mosquito bites on human. So try understanding, it may be a little bit complicated. One microfilaria per 40 millimeter cube of blood will infect 2.6 mosquito bites. So this could be your potential MCQ, that this is the amount of intensity by which the mosquito may be infected by the humans. Next is, if we talk about the host factors. Host factors, it can affect any age, but maximum it affects 20 to 40 years of age. Why? Because these are the people who may be outside. Again, the same issues, that it may be linked with the occupation. Next, if we are going to talk about the environmental conditions. Environmental conditions, the temperature that is suitable for this mosquito is same answer. It is 20 degrees to 30 degrees centigrade with a relative humidity of 60 to 80%. So what is the water this mosquito loves to breed in? The mosquito, that is the Culex mosquito or the Mansonia mosquito, these are responsible for lymphatic filariasis, and they love to breed in Culex and Mansonia. So Culex is for dirty, polluted water, and these are in large water bodies like ponds or lakes with aquatic vegetations. So you have Culex mosquito and Mansonia mosquito, which are primarily responsible for spread of this lymphatic filariasis. If you talk about the vector a little bit more in detail, the Culex fatigans, that is the Culex quinquefasciatus. This is the same name, right? Culex fatigans or the quinquefasciatus is the same name. This is the primary vector for Bancroftian filariasis. Whereas if you see the Brugian filariasis, that is primarily caused by the Mansonia mosquito. So Mansonia is Mansonia uniformis mosquito. So that is primarily by Mansonia uniformis, or in India we have Culex fatigans, that is the primary vector for transmission of lymphatic filariasis. If you talk about the incubation period is like too much varying. It varies from 6 to 8 months in the lowest possible till 15 to 18 months in the maximum possible. So that is the large incubation period. Next, if you talk about the clinical features of this disease, there are 4 basic types of clinical feature. We can have or detect microfilaria, or we cannot detect. The patient may have symptoms or may not have symptoms. So these are your 4 broad categories. So the clinical features could be asymptomatic, filaremia, or we can have an asymptomatic microfilaremia, right? Or we can have stage of acute manifestation, that is when the disease starts spreading, and last is the stage of chronic disease. A few points about each of them. Asymptomatic A microfilaria, that means this is a subtle infection where the microfilaria are not found in the blood. If the microfilaria are found and the patient is still asymptomatic, these type of patients are the MCQ, these are the most common sources of infection, obviously, common understanding. If we talk about acute manifestation, we are going to talk a little bit in detail about the clinical features of lymphatic filariasis, but broadly speaking, it will cause fever, it will cause lymphangitis, swelling of the lower limbs, and all these things. Stage of chronic disease, that this microfilaria stays in the body for very long time. It may stay in the body for 10 to 15 years after the onset of the acute disease. So that is the point which is responsible for which is a main deterrent for early elimination of lymphatic filariasis. Are you getting it? And this is of positive. You can see this point from two viewpoints. One is that there is no extra development. That is a positive point. But the negative is it is going to stay in the body for a very long time. Now the positive is it is going to stay in the very body for a very long time, but without development, without multiplication. Are you getting it? So that gives the National Health Program a chance to hit this lymphatic filariasis. So that is how we have this lymphatic filariasis. If you broadly see the clinical features can be the stage of lymphatic filariasis, or we can also have occult filariasis. Occult filariasis. What is occult filariasis? It is nothing but a hyper-responsiveness of the host to the infection. This does not cause disease. There is no filariasis, but the filaremia, but this patient is symptomatic. That is known as occult filariasis. And lymphatic filariasis is what you have already seen. There could be asymptomatic without filaria, asymptomatic with filaria, or there could be symptoms with filaria, of course, right? So there is another clinical presentation that is known as ADLA. ADLA, acute dermatolymphangioadenitis, acute dermatolymphangioadenitis, ADLA. Now the ADLA is a severe disease which may require complete antibiotic course plus antipyretics, and it may require it for a considerably longer time. The antibiotic which are recommended by Government of India are oral amoxicillin or penicillin or erythromycin. So these are your drugs which we use for ADLA. In case it is severe ADLA, of course you will use IV penicillin. So ADLA is primarily responding to the penicillin group of drugs or the cell wall inhibitors, and the oral amoxicillin, erythromycin, all these are used for severe ADLA. However, coming back to a story of lymphatic filariasis. So if you talk about the clinical features of lymphatic filariasis, that is the stage of acute disease. The stage of acute disease can have two broad areas of manifestations. So one is we can have lymphedema. Lymphedema can be broadly affecting two organs. One is the limbs, another is the genital area. If you talk about the genital area, it may lead to hydrocele, chylocele, swelling, gross, large swelling of the scrotum or the penis. So that these are your lymphedema features. The other organ which is associated, which is usually affected, is kidney. There is renal damage. Renal damage may manifest as protein leakage. Protein leakage, or there could be plus or minus hematuria as well. But of course, protein leakage is one characteristic feature of renal damage. It is estimated up to anything between 20 to 40% of the people may have renal damage associated with this lymphedema. So this disease has a couple of positive points as well. That there is a chance to eliminate disease, there is a treatment for this disease, there is a possibility that the suffering can be stopped, right? So that is the reason this program is being formed by Government of India. Coming to the next point about diagnosis of lymphatic filariasis. If you talk about diagnosis of lymphatic filariasis, the investigation of choice is forming a thick film or a peripheral blood film. Now the point is that we conduct a microfilaria survey across the villages, across the districts. The activity of the microfilaria, we already told that it has nocturnal periodicity. So it is maximum active during what time? During the midnight. So the survey has to be done from 10 p.m. in the midnight till 2 a.m. in the morning. So this is the time for conducting the microfilaria survey for making a thick film for direct identification of the parasite, peripheral blood film. Other methods that can be used is use of membrane filter concentration method, membrane filter concentration method, MCQ. This is considered as the most sensitive method. This is considered as the most sensitive method to diagnose lymphatic filariasis on a large scale. But it may require some specialized instruments and specialized devices and specialized laboratory techniques. That is the reason we do not use membrane filtration. We have simple plain film, peripheral blood film as conducted as a mass survey, or we call it as a filariasis fortnight. So in those 14 days, we will check for a survey for lymphatic filariasis across the village. The third test we can have is again an important test, and it is having very high specificity, that is known as DEC provocation test. So either we can have a membrane filtration method or we can have a DEC provocation. Simple answer, DEC, you give DEC and you examine that the filaria are there in the blood. So that is seen at 1 hour after giving DEC. How much DEC we give is 100 milligram tablet orally. So you give oral tablet of 100 milligram. After 1 hour, you check for the DEC, for the microfilaria, that is known as DEC provocation test. So these are your laboratory tools for diagnosis. Out of them, under the program mode, what are we using? We are using peripheral blood films. Other methods for diagnosis could be clinical examination. Of course, if there is clinical examination, that the features of lymphatic filariasis you don't tend to confuse with anything else. There is fever, there is big swelling, also known as elephantiasis. So all these are like features of lymphatic filariasis. Next is we can also have another type of examination, that is the serological examination. So serological test is not very important, but you have this antigen or antibody testing. But the problem with this serological test is that try understanding that the same problem is there, that the microfilaria will stay in your body for a very long time. Because it stays in the body for a very long time, there is more antigen or antibody production, and serological test cannot distinguish between past infections or the current infections. So between previous infections or the current infections, there is a lesser chance for a serological test, and therefore we don't use this. Clinical examination you don't use, because by the time the patient develops clinical examination, then it's pretty late to do the treatment, right? Then you need a lot of management, hygiene, antibiotics, a lot of things are required. And third is another type that we can do is xenodiagnosis, not used in India, right? So with that, we have seen what are the investigation of choice. Coming to the next point, that is about the treatment of filariasis. Prevention and treatment of filariasis. That should be a better point to say. So let's talk about the treatment first, because of course you all are clinical doctors. So we need to talk about the treatment with you first. What is the drug of choice? The drug of choice is DEC, diethyl carbamazine. DC is pretty effective. It starts working within 12 to 24 hours, and it is found to be highly effective for control of microfilaria. So DC is given at a standard dose of 6 milligram per kg body weight. So now in case of treatment, that is chemotherapy, we are going to give DEC plus albendazole. We are going to give DEC plus albendazole. DEC will be given for 6 milligram per kg body weight, given for 12 days. It is given for 12 days. 12 days mean how many weeks? Roughly 2 weeks. So in 14 days, we give it 6 days in first week and 6 days in another week. That is how we give. So it is given not 12 days continuously. It is given as 6 days plus 6 days in 2 weeks. Right? Next, we also give albendazole. Albendazole is given as a single tablet, 400 milligram single dose, 400 milligram single dose, given either in between or on first day. This is given only to people who are more than 2 years. So children who are more than 2 years, we give albendazole, plus we will give them DEC, given at the rate of 6 milligram per kg body weight for 12 days. Total dose is how much? 6 12 are 72. 72 milligram per kg body weight is the total dose. That is the total dose required for chemotherapy. This is not prevention. This is not mass drug administration. Next, we come over to is mass drug administration, prevention of filariasis. That is mass drug administration. If you talk about the mass drug administration, please remember just a lateral MCQ for you to remember that mass drug administration is given for couple of few diseases like scabies, like trachoma, like lymphatic filariasis. So not in all diseases we give these mass drug administration. The mass drug administration consists of annual supplementation or annual drug administration, annual mass drug administration of DEC at the rate of 6 milligram per kg body weight, 6 milligram per kg body weight plus albendazole at the rate of 400 milligram to all people who are age more than 2 years, and in case of age more than 1 year but less than 2 years, 1 to 2 years. In those cases, we will half the tablet, that is known as albendazole. Now, there is a new thing for you to remember that recently WHO has recommended in year 2017, adopted by Victor Born in 2017 only, because this was a big trial, death of oncofilariasis and lymphatic filariasis, DOLPH trial. DOLPH trial results were shown, and they were saying that 2 drug administration is very good, but we should also have a 3 drug administration. So what was DOLPH trial? Death of onchocerciasis and lymphatic filariasis. So the DOLPH trial recommended the WHO recommended inclusion of ivermectin. In fact, the ICMR, Indian Council Medical Research, was the key player in recommendations of the ivermectin. So it has been taken up by India last year 2018, and it is almost there in many states. Of course, still much way to go, because not all states are able to afford or not able to give the TDT. This is known as triple drug therapy for MDT, for MDA, mass drug administration. But standard drug that we were giving, that we are still giving, is annual dose of DEC plus albendazole, and TDT is DEC plus albendazole plus ivermectin at the rate of 150 to 200 micrograms, and this is the standard dose. So, but DEC ivermectin is plus or minus, and for mass drug administration. So, talking further about the preventive measures, what extra MCQ can be asked is there is also provision for DEC, medicated salt. What are the DEC medicated salts? That many states have done this. Maharashtra was one of the states which pioneered this, which started this. DEC, if given in the salt, it is like it has good shelf life and it has high effectivity that it reaches even the poorest of the poor. So DEC medicated salt have actually shown a very effective public health measure. DEC is to be added at the rate of 1 to 4 grams per kilogram of the common salt, and if circulated it forms as a very important measure. Next point number 2 is that about the vector control. So how to control the vector management? Of course, if you have gone and seen about the video in the NVBDCP, we must have talked about the vector control over there as well. So there are some special features about this vector control. What vectors we are going to talk about? The Culex mosquito and about the Mansonia mosquito. You know that Mansonia is in large water bodies. Culex is in dirty polluted water. So now you need to formulate your vector management protocols accordingly. The vector management strategies under the program could be, first is anti-larvals. Anti-larvals, we can have physical methods which are predominantly used. The physical methods could be mosquito larvicidal oil, which I know is more so for Anopheles, but it is also applicable for Culex and Mansonia. So mosquito larvicidal oils, or we have pyrocene oil. What is a pyrocene oil? It is an emulsificant which contains pyrethrum extracts or pyrethroid extracts with an oil. So that is known as a pyrocene oil, and it has been shown that it is highly effective at the rate of 0.1 to 0.2% pyrethrin strength in the oil. It causes a lot of larva to die, contact poison. Then we also have other chemical methods. Of course, the one best which is used is fenthreon, and you have temifos. These are one of the most important and most widely used anti-larval methods. The anti-adult measures can also be used, especially because for Mansonia and Culex both are outdoors during the daytime. So anti-adult measures could be use of DDT, lindane. BHC is to be kept as an alternate. So DDT, lindane and malathion sprays, these are particularly important. Malathion is to be sprayed 3 to 4 times a year, and DDT is to be sprayed 6 monthly. It is to be sprayed 6 monthly. So you can have anti-adult measures. Then you also have some anti-larval measure like removal of, next point is removal of aquatic plants which may harbor the Mansonia infection, Mansonia mosquito. If you recall the video from entomology on mosquitoes, I would have told that which aquatic plant is required for Mansonia mosquito breeding. It is 2 plants, that is pistia plants, water hyacinths. So water hyacinths and pistia plant. So removal of these plants will also lead, you remember that the larva attaches to the root. So if you pluck out the plant, if there is de-weeding of the lakes or the ponds, that will obviously going to decrease the Mansonia endemicity in the area. So these are your most of the anti-larval and anti-adult. Next is we are going to talk something about the WHO lymphatic filariasis elimination strategy. So the amount of aggression which is there in the program, the amount of funding which is done in the program, this becomes as a 5-star topic for you because of the chance that this may be asked in the exam. So please remember that under the lymphatic filariasis, the recent advances is, first is launch of triple drug therapy for lymphatic filariasis. Second, under the lymphatic filariasis elimination strategy, what they have done is that there is something known as mass drug administration, you already know. Now the point is that if the mass drug administration is given to the community with, listen very carefully, every word will be an MCQ. If the mass drug administration is given to the community with at least more than 65% coverage, with at least more than 65% coverage in the area, and it is done for minimum 5 to 6 years, 5 to 6 rounds of MDA. How many rounds you do in a year? One round. So how many years we are talking is 5 to 6 years. If you're giving 5 to 6 rounds of mass drug administration with 65% coverage, it is expected that the microfilaria will be less than 1% in community. So if the filarial rate in the area is less than 1%, we think that this will be an elimination level. Elimination level. A small MCQ which may confuse you. Sometimes some books may say something differently. What Government of India, what National Vector-Borne Disease Control Program has done is that in all states, they want that the MDA should be given, because in some states we are giving 2 drugs, some states we are giving still 3 drugs. So in some states, differential drugs are there. Plus, there is a lot of logistic problems. Many things are happening. So Government of India, Vector-Borne has taken that the coverage should be at ideally 80%. So if you get two things that under the Vector-Borne, 80% is also there in the option. I would recommend you to mark 80%. If 80% is not there in the option, the WHO is already said that at least keep 65. Are you getting it? The ideal form is 80%. The lymphatic filariasis elimination strategy by the WHO is at least 65%. So all the states which have already achieved 65, they are going to achieve 80. All the states which have already not yet achieved 65, then first need to achieve 65. So if you get both the things, MCQ, if you get both the options like 65 and 80, I would suggest you to mark the 81 because that is the ideal percentage of coverage. But WHO says 65. So that is the elimination strategy. So if you see the lymphatic filariasis status in India, next coming to is the status of lymphatic filariasis in India. If you see, can you see on your screen that there are two predominant areas for lymphatic filariasis according to your MCQ exams? I'm talking that there are the thing can be remembered as that in India two areas are involved. One is the Bihar belt and another is the coastal areas. Can you appreciate the fact that this whole areas, all the coastal area is affected? Can you appreciate this? That in coastal areas, so what are the states which are in the coastal areas? You have Odisha, Andhra Pradesh, Telangana, Tamil Nadu, Kerala, Maharashtra, some areas, and some areas in Gujarat as well. So these are your coastal belts. And predominantly it is there in the Bihar belt. You recall that we discussed in Japanese encephalitis also many diseases that Bihar belt is like predominant for most of the vectors. So what was there in the Bihar belt? Bihar was there, Uttar Pradesh is there, West Bengal is there, and below you have Jharkhand. So these are your Bihar belt plus the coastal areas. Of course, there are some areas in Maharashtra, some areas in Madhya Pradesh also, which you need to remember. So this is the status of the country India. And please remember, there should be more than 5 to 6 rounds with more than 65% coverage in each round for the MDA. Now, do you know that after this, once you conduct MDA, once you conduct 5-6 rounds, now your country will be applying to the WHO. So that means that, do you know that if the country completes 5 to 6 rounds of MDA with 65% coverage, they will apply to the WHO. Now the WHO will conduct a TAS survey, transmission, assessment, survey. So the TAS survey is conducted and again the microfilaria rate in the area is calculated. So number of people, if it is less than 1%, again 5 rounds of MDA will be done. Again TAS 2 survey will be done and then the country is said to be filaria eliminated. So that is the level of filariasis endemicity to be finished elimination level to be there, that you should have two task surveys, task survey 1 and task 2. Task survey 1, each task transmission assessment survey will be conducted after 5 to 6 rounds of MDA with at least more than 65% coverage, and there should be evidence of less than 1% microfilaria rate in the country, right? So that is the level of elimination that we are going to achieve. So coming to the last topic, that is monitoring and evaluation indicators for the lymphatic filariasis program, control program. So the evaluation can be based on 4 broad indicators. These are filarial indicators, filarial control indicators. First is microfilaria rate, filarial endemicity rate, microfilaria density, and average infestation rate. So I think you'll ask me that all these look to be same. Microfilaria rate means filarial endemicity rate, which means microfilarial density rate, which means average infestation rate. So what is the difference between all them? Please try to understand, very small subtle differences are there. Microfilaria rate, it is defined as the number of persons with microfilaria in their blood in per 20 millimeter cube of blood. So number of persons who show microfilaria in their blood divided by the total population under survey multiplied by 100, it is usually expressed as 100. That is the microfilaria rate. What is filarial endemicity rate? It is the percentage, it is the number of persons who are microfilaria positive on this slide or disease or clinically diagnosed disease. You remember there was something known as asymptomatic amicrofilaria, asymptomatic microfilaria, acute disease or chronic. So this second indicator, that is filarial endemicity rate, will take into account the microfilaria people plus the clinical disease people. Microfilaria rate will tell you only about the filariasis, number of persons with microfilaria in their blood. So number of persons with microfilaria with disease clinically diagnosed divided by the total population under survey multiplied by 100, this is known as filarial endemicity rate. Next is microfilaria density. Now what is this microfilaria density? Microfilaria density is the percentage of microfilaria per unit volume of blood. Percentage of microfilaria per unit volume of blood. What is this average infestation rate? It has two sub-indicators or two sub-parts. Average indicator is average number of microfilaria per positive slide. That will be known as average microfilarial infestation rate, or it also indicates about, there is another sub indicator, that is the prevalence of microfilaria in the area. Try understanding. There are 4 things I have told you. What is microfilaria? Out of the total population, how many people have microfilaria? That is known as microfilarial rate. It will tell you about what? It will tell you about MCQ. It will tell you about the prevalence of infection or disease. It will tell you about the prevalence of infection. Okay. How much, or the prevalence of microfilaria? That is what is prevalence of microfilaria. It is nothing but filarial rate. What is filarial endemicity rate? It is number of people who are suffering from the disease. So this will tell you about lymphatic filariasis prevalence or prevalence of disease. Can you understand this? This is lymphatic filariasis prevalence of disease. So the prevalence of disease is given by filarial endemicity rate. Microfilaria rate will tell you about the prevalence of infection. What will the microfilaria density tell you? What will this tell you about? Microfilaria density. It is the amount of microfilaria in every drop of blood. So don't you think this will tell you about the intensity of infection? It will tell you the intensity of infection. That means how heavily people are infected. That means what are the chances of having outbreak or endemicity potential. It tells you about the endemicity potential of the disease. It tells you about the endemicity potential of the disease. What is the use of average infestation rate? Nothing very special. It is again average infestation rate is similar to the microfilaria rate. It tells you about the prevalence of microfilaria in the area. It is average microfilaria in every positive slide. It tells you about both the things. It tells you about the intensity. It tells you about the microfilaria in the prevalence in the area as well. So out of these, which is the most sensitive indicator for assessment or evaluation of the program? Please remember the most epidemiological indicator, the sensitive indicator is microfilaria rate. Filarial endemicity will tell you about the disease per se, right? It tells you about the number of people with microfilaria or with clinical disease, but the whole game is actually dependent on the microfilaria rate. You remember in TAS1 survey, what we were surveying? We were surveying the microfilaria. Less than 1% in people, there is chance of elimination. That means you have cut the transmission system. So with that, we like to close this topic on lymphatic filariasis. We have discussed about epidemiological aspect, prevention control aspects, treatment and investigations for lymphatic filariasis. Thank you.